Good afternoon, everyone. I'm Yung Lin Chen from Kaohsiung Veteran General Hospital. Today, I would like to share a topic of reconstructive treatment with stent graft for carotid block syndrome. First of all, I would like to give special thanks to Professor Zhang Fengji and the carotid block team from Taipei Veteran General Hospital for all the concepts and experiences sharing. These are my content and outline. The incidence of head and neck cancer in Taiwan is significantly higher than the global average and is the fifth most common cancer in Taiwan. And most of the patients of head and neck cancer receive radiotherapy, and about 4% of them will develop post-irradiated carotid block syndrome, and even higher, up to 6 to 10% in advanced cases. And the risk factors include radiation-induced necrosis, recurrent tumors, wound complications, or pharyngocutaneous fistula formation. And if it received previous radiotherapy, radiation, and carotid block syndrome risk will increase about 7 to 8-fold. Maybe it's due to the perivascular soft tissue injury to the carotid artery. We all know the carotid artery or normal artery have 3 layers: intima, media, and adventitia. And 80% of the blood supply comes from adventitia. So the perivascular environment is very important. If any perivascular soft tissue injury can cause ischemic insult to the wall. The old clinical classification of carotid block syndrome including impending, threatened, and acute. And Professor Zhang proposed simplified into 2 categories: ongoing and acute for non-emergent and emergent status. He also proposed the angiography severity of carotid injury from grade 0 to grade 3. Grade 0 means normal or no bulging lesion. Grade 1 means focal irregularity, indicating focal weakening of the vascular wall. Grade 2 means pseudoaneurysm formation or focal bulging. It's a tiny vascular rupture confined by adjacent soft tissue. And finally, a grade 3 active extravasation is complete rupture of the vascular wall. And Professor Zhang finds there's good correlation with the modified classification and the angiography severity. So it can guide the therapeutic planning. If it's in an acute status, then an angiography, emergent angiography is indicated. But if it's ongoing status, then a CTA may be considered. And if it's it's hard to determine acute or ongoing, then treat it as acute. And previous studies also revealed early intervention can improve outcome. In the group of threatened or ongoing carotid block syndrome, there's lower rebleeding rate. So early treatment brings and reduces the risk of future rebleeding and establish a foundation for prevention of the carotid block syndrome. Because it is better to treat the carotid block syndrome in ongoing status than acute. Because in acute status, there are worse clinical conditions, and sometimes the vascular collapse of ECA may cause miss a lesion. And it's difficult to finish a complete balloon occlusion test in acute status, and no pre-medication DAPT for stent graft. And besides, there are ongoing, there are acute, and maybe there will be potential carotid block syndrome we can prevent. There is perivascular recurrent tumor encasement and aggressive treatment like radiation. So the imaging diagnosis of the carotid block syndrome follow iceberg imaging pattern. The visible part is vascular lesion can be evaluated by angiography and CTA. And the perivascular lesion is a hidden part, can be evaluated by CTA, CT perfusion, and vessel wall imaging. These are the 6 main CTA signs of carotid block syndrome. The top of the 3 is a vascular lesion, and the lower 3 is a perivascular lesion. The first one, pseudoaneurysm formation and extravasation, is the most simple and pathognomic for carotid block syndrome, but sometimes it's not conspicuous when it is in distal branch of ECA. And the second one, vascular lesion, is a nose of normal axial round shape. We can see the disease artery here is an oval shape, and the normal one is round shape. This indicates the focal weakening of the diseased artery. The case in outside hospital, for example, this is a case 5 months before blowout. We can see the sign of loss of normal round shape here, and a blowout it seems more oval shape and more irregular. And in coronal plane, we can see the medial side focal outbulging. Angiography is an evident extravasation from the pseudoaneurysm formation. And we do a long cover stent from ICA to CCA and glue embolization of the ECA, which we call dynamic drilling embolization technique. I will introduce it later. And the third sign of the vascular lesion is displacement toward the soft tissue lesions. It's a case of acute carotid block syndrome, and 3 days before, the vessel is not ruptured yet, but we can see the displacement ventrally and laterally as compared to the normal side and toward the soft tissue lesion. And there is also loss of its normal axial round shape. This indicates the loss of focal soft tissue support. It's a case in our hospital. Just 20 days before blowout, we can see loss of normal round shape and evident displacement. And a blowout is the extravasation from the ECA stump. In this case, we deal with a short cover stent with coil embolization for ECA. And 4-month CT revealed patent stent, but the patient expired 8 months later due to tumor progression and other causes. So now going to perivascular lesions. Soft tissue injury or necrotic tumor adjacent to the diseased carotid artery. If is there any perivascular lesion, we recommend close follow-up because the soft tissue lesion can have dynamic changes. Especially have gaseous lesions is most dangerous. The first perivascular lesion is adjacent soft tissue necrosis with fluid or gas collection. It can cause ischemic insult to the wall. It's a case in our hospital. 5 months before blowout, we can see perivascular soft tissue necrosis. And at blowout, there are more gaseous lesions. And we also do successful cover stenting and dynamic drilling embolization. And 2 months follow-up, we found the stent is pattern, but there is surrounding soft tissue necrosis, so need close CTA follow-up, like 1 month and antibiotics treatment. And this patient follow-up CTA, but tumor still progression. You can see more and more tumor growth around the stent, but no massive bleeding, no stroke. At 5 months, the previous necrosis disappear, but at 7 months, there is new necrosis, new infection. So we have a stent extension to protect the diseased vessel of proximal CCA. And it is still patent at 8 months. A second perivascular sign is soft tissue defect. And third sign is recurrent necrotic tissue with encasement of the carotid artery. In this case, we can see it's an evident extravasation, and 3 weeks before, it's a necrotic tumor with encasement. It's a case in our hospital. 3 months before, he have a recurrent tumor with encasement of the proximal CCA. And 3 days before the procedure, we see large soft tissue defect and pending exposure of the vessel. So prevention is recommended by our report. We use a balloon expandable coronary stent, cover stent, about 4.8 millimeter, and overlapping with a wire bond about 7 millimeter. The stent is patent, but patient still expire 2 weeks later. So these patients usually have poor outcome and poor prognosis due to their disease status. Another case, 2 weeks before procedure, there is a recurrent necrotic tumor with encasement in distal cervical ICA and even into the petrous ICA. We also use a balloon expandable stent and a wire bond. After successful stenting and dynamic jelly embolization, and 1 month later, it's still patent. But we found the new soft tissue defect and pending exposure. So we recommend close CTA follow-up and aggressive antibiotics. These are the endovascular treatment options for carotid blood syndrome. Embolization or stenting plus ECA embolization with glue, or stenting with embolization of ECA by coil and by glue. In pure embolization, we need to pass the balloon occlusion test, but even we pass the balloon occlusion test, it's a false negative rate up to 10%, and it's difficult to perform in acute status. And in stenting, we don't need the occlusion test. But for DABT, the stenting requires pre-medication and should have aspirin lifelong after 3 months. The rebleeding rate is similar, but neurological complication, the embolization often happen peri-procedural, and the stenting is often delayed. And the ECA embolization is only main trunk in this group and coils plus stenting. But it can be trunk and branches in the glue group. And the problem of the long-term problem of the stenting is more like marginal stenosis, in-stent thrombosis, or septic thrombosis. Okay, this is a stent we choose. If it's an intracranial, we use wire bond because they have heparin coating and good patency rate. And if intracranial, we usually use Grabmaster, but it's hard to push and pass. And some hospitals like Taipei Veteran General Hospital, they have Bitronic PK papyrus balloon is softer than Grandmaster and more easier to pass the lesion. So medication for stent graft placement is important. We usually recommend the 300, aspirin 300 milligram and is 300 Plavix, and the night before the procedure, and then one aspirin and 1 Plavix after. And antibiotics is also important for long-term stent patency, and recommend close CTA follow-up in 1 year. The result of the carotid blowout syndrome treated with reconstructed or disconstructed treatment of the Taipei Veteran General Hospital team shows similar rebleeding rate and similar neurological complication rate overall, but there is less peri-procedural neurological complication in the stent graft group. A similar finding in intracranial CBS. So the endovascular reconstructive method with cover stent, including external carotid artery branch occlusion, seems feasible and preferred to occlusion of the internal or common carotid arteries. There are some technical challenges, complication of the stent graft, like reconstitution of the ECA. Okay. Septic thrombosis or marginal stenosis. Okay, finally, I would like to introduce the dynamic drilling embolization technique. It's a microcatheter placed in advance, and it's safe MBC injection due to stasis or reverse flow of the ECA-ICA anastomosis or other critical anastomosis after stenting. And we need one assistant control the pushing and the other one control the catheter pulling out. There are 4 dynamics for 4D. The initial location and the concentration, injection rate, and the rate of catheter pulling out can be personalized for every different cases. Endpoint is a glue touch stent or the superior thyroid artery occluded. And it's a cases amount in our hospital in recent 2 years. We have 12 cases with valve in neck and 4 cases for intracranial CBS. And what I learned from these cases is pre-medication have better prognosis. The lesion in neck have better prognosis than intracranial. And even in acute bleeding, the patency rate is still high if only valve is used. And peri-procedural continuous aggressive use of DPT and antibiotics is very important. So conclusion is carotid blowout syndrome is potentially preventable, and early CTA, early detection is important. Close follow-up is important, and stent grafting reconstructive treatment can be a potential routine. So it's a dynamic drilling embolization technique we use. So location of the catheter tip can be, okay. If it's NPC, the location can be in internal mesenteric artery. If it's lower neck cancer, then the catheter tip should be in superior thyroid artery. And the non-target lesion will pull in fast and inject slightly. And in the main target area, we slow down the pulling rate and push it harder for more glue, and stop when it touches stent or the superior thyroid artery is occluded.
Okay. So I think, Dr.
Okay.
Chen, okay, it's Ann. Okay, thanks, Dr. Chen, for his a very detailed, introduction for the managing carotid blowout syndrome.